أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. Now, an approach to the patient of the breathlessness. This is a tutorial for the final year Mbbs in Pakistan, for the Pakistani population. It's not the outside for the outside countries. In most of the cases of the outside countries, they want shortcuts. They do not want to listen the lectures. They do not want to appreciate the tutorials, and they want only 5 minutes, 7 minutes talk in micro teaching. So I don't think so. The micro teaching can help in the clear conception of the disease. So I am out of it. I do not want to participate in their activities. And I am Professor Sayyid Ali Hazar. As you know that I am the visiting professor of medicine in Sindh Medical University, Karachi, Pakistan. A case scenario. A 60-year-old farmer, smoker, alcoholic and non-hypertensive, presented in emergency and severe breathlessness state for the last 8 hours. He was unable to speak because of the severity of the dyspnea and wanted to sit on the corner of the bed and quiet. On examination, temperature is 99, respiratory rate 42 per minute, blood pressure 170 by 100, which is higher. Respiratory rate tachypnea, blood pressure is stage 2 hypertension, pulse is 110 per minute, which is high volume, it's a regular pulse. Pedal edema was positive, central cyanosis was positive. Grade 3 digital clubbing on the ophthalmos, on the clubbing is present, and on ophthalmoscopy evidence of the capillary edema. It is a classification, it is Keith-Wagner classification, and it is a grade 4 type of the retinopathy. Flapping tremors present, flapping tremors, hysterexis, that is also known as hysterexis. The heart sounds intensely low. Heaving of the right ventricle, there will be apex beat which was displaced, and heaving in character, and there was a pansystolic murmur at the tricuspid area. There was a diastolic murmur present also at the pulmonary area. And chest full of coarse capitations. Liver was 3 centimeters palpable. It was also pulsatile liver. Urgent investigation is done. Cardiac specific troponin I was negative. The saturation at the bedside is 82%. X-ray test was done, PAView, which I will show you, and then there was electrocardiogram, which I will show you. Now this is the X-ray. Look, this X-ray. It is PAView, and it's definitely very of high voltage X-ray was taken, and the bony requirement are fulfilled. The bony skeleton was normal, the trachea is central. This is important negative findings. If you are telling positive finding, you have to mention the important negative finding. Otherwise, the X-ray statement interpretation will be wrong. The lungs, there are bronchoscopy markings that are very thin, and you cannot pinpoint without the help of the magnifying glass. Flattening of the dome of the diaphragm is seen here, and there was a middle mediastinum. There is definitely enlargement of the heart, and the apex is like this. This is the apex. Look the direction of the apex. It is transverse, which means the predominant is right ventricular hypertrophy, and about the right border of the heart is bulging. It should be very near to the sternoclavicular joint, 1 centimeter, not more than that. If a line is drawn here, it is out of it. It is protruded out. So the other thing is the upper part of the middle mediastinum. It is divided arbitrarily for the learning purposes into 4. I will draw a line here, 1, and second is the transfer line. The first line represents the ascending aorta. The second and the third area belong to the arch of aorta. Look, the aortic knuckle. And the fourth area, which is seen here, which is bulging out, very much prominent and out. It is much dilated and it is prominent. This is the pulmonary conus, and this is the highly attenuated area which is seen here. And then go for the electrocardiogram is concerned, and the requirements of this X-rays. This is the important point. Here, there is 1, 2, 3. This is there is AVF and AVL and AVR. Now AVR, because it is upper, you have to see that there is an evidence of enlargement of the heart or not. The heart is enlarged academically, and there is excess deviation. Probably the AVR should be up in this case, or it is right bundle branch block, or it may be also associated with this up. So in this, there is evidence of the right ventricular enlargement is seen, because in this ECG, P1 show the prominent R wave, and in the leads downgoing, V5 and V6, there is prominent S waves. So because of this, the AVR is up. The other things are the voltage is normal, no problem, the voltage are conserved. And then what we see after the voltage is, I have told you previously many times, that after this you have to rate the heart rate. 300, 100, 50 and 100, around 100 per minute. Tachycardia, sinus tachycardia. And then we go for the PR interval, QRS interval, and QT interval. And the lead 2 you can see, they are normal. Rhythm is described depending upon the requirement you can fulfill. Long lead should be taken. The long leads should be taken. At least 6 complexes should be there to comment on the rhythm. Otherwise, you cannot comment on rhythm on the heart is concerned. And in this case also the RR durations and the PP durations should also be mentioned here. It is equivalent. PR interval, QRS interval, QT interval should be normal. The requirements are fulfilled for the rhythm is concerned, it is regular rhythm, sinus rhythm. Then we go for what we see here afterwards. Rhythm is normal, it means axis should be calculated. 1 and AVF. The 1 is down, AVF up, there is right axis deviation. The angle should be, if it is calculated, it should be more than plus 110. Around 130 it is. I have calculated 135. In between, this is 100 degree or 90 degrees now seem to be normal. According to the American Heart Association, plus 110 is normal. Minus 30 to plus 110 is normal. It is more than 110 is right axis deviation. It is more than minus 30 left axis deviation. So it is right axis deviation. And then we go for the hypertrophy. First of all, the atrial hypertrophy. I will take the lead AVF or 2, best demonstrated here. Let's see the P wave. Measure it on the vertical axis. It is 1, 2, 3.5 millimeter. 2.5 millimeter is normal. It means that it is in this condition what we say is P pulmonale. P pulmonale is very clearly visible. The duration is normal, 3 small squares, but there is no P material. Always said that the right ventricle is enlarged in this case because one need to be one that is prominent R wave, and in B5 and B6 the prominent S waves. About the left ventricle is concerned, there is no, in this case, S wave, and B5 there is R wave, so it is definitely normal one. It should be S wave plus R wave of the V. It should be summed up. If it is less than 35 millimeter, it is normal. If more than 35 millimeter, there is left ventricular hypertrophy. The right ventricular enlargement or hypertrophy is visible, clearly evident. Ischemic changes, 1 AVL representing the lateral wall, nothing significant is seen. In the 2 and the 3, yes, in the 3, you see there is flattening of TV inversion, but adjacent leads should be checked out for 2, it's normal, AVF, it is normal. It is nothing. It means that it's significant. It is not significant. About the anterior wall is concerned, there is deep S wave are seen here, like this. Although they are non-symmetrical, it is strain pattern. Here ST depression is very clearly evident. Isoelectric line ST depression. V3 ST depression. V4 ST depression. V5 ST depressions of more than 1 millimeter. V6 no ST depression. It means that there is overall the left ventricular or the right ventricular, there is ST depression, means that ischemia occurs because of the enlargement of the heart. It is the mismatch of the supply and the demand. So inference is that in this case there will be positive finding the sinus tachycardia with right axis deviation, the evidence of the corpulmonale, that is P pulmonale means corpulmonale. And there are evidence of ischemia in the right-sided chest leads, right ventricular leads, also some of the left ventricular leads. Now this is the inference, and the diagnosis depending upon this is corpulmonale. You go for the echocardiography, and X-ray test already done. You can go for the catheterization studies to confirm. If it is more confirmed, you do it. And the other differential diagnosis should be congenital heart diseases, which can cause these problems, which cause the high pressure in the right ventricle, causing these same changes. The left ventricle usually is not involved, the right ventricle is involved. It's called Eisman-Gertz reaction, Eisman-Gertz complex, or Eisman-Gertz syndrome. But there is evidence of Eisman-Gertz syndrome in this electrocardiography with corpulmonale. This is the final one. Now the questions are the same. What is the on-spot diagnosis? It is the corpulmonale and the Eisman-Gertz reaction is seen in this. What will be the underlying diagnosis? It is due to the, probably because patient was smoking, there was chances of high pressure. That is why I say that Swan-Ganz catheterization, it should be done to differentiate that it is not due to the high left atrial pressure which is causing. It can be done. If it is not done, it is a right ventricular hypertrophy corpulmonale. Underlying diagnosis is secondary pulmonary hypertension. How do you further investigate? Already done. How will you manage in AE and follow-up measures? Relieve the symptomatology. This is the first right of the patient. So he is very, very dysnic. Go for the management of the congestive cardiac failure. Now, corpulmonale means pulmonary heart disease, also known as corpulmonale. is the enlargement and the failure of the right ventricle of the heart as a response of the increased vascular resistance, such as, for example, pulmonary stenosis, for example, back pressure of the PDA or a VSD, or a high pressure in the lung from the left side mounting to the right side, then will cause this increased vascular resistance. It may be without any cause, like primary pulmonary hypertension. It is possible. The classification can be done according to the duration of corpulmonale and according to the etiology of the corpulmonale. According to the duration, acute corpulmonale occurs in the ARDS, which I will discuss later on. Pulmonary embolism I will also discuss later on. My tutorial will be on the ARDS and the pulmonary embolism afterwards. Now, chronic corpulmonale is seen in COPD. As you say, the COPD has been discussed by me. And primary pulmonary hypertension, I already said, this is an important disease. Blood clots in the lungs, there is thromboembolism in the lungs, kyphoscoliosis will increase the AP diameter and will cause definitely the difficulty in the inspiration or expiration. As a result, there will be burden on the right ventricle because of the less oxygen. Ischemia is the major cause of the pulmonary vasoconstriction. Interstitial lung disease will cause the same thing. Cystic fibrosis, bronchiectasis will cause the same. Sarcoidosis will cause the same. Obstructive sleep apnea, because patient has obstruction in the upper passages, and because of the weight, that's called Pickwickian syndrome. If untreated, it will ultimately result in the chronic corpulmonale. Sickle cell anemia, why? Because it will cause blood clotting and increased viscosity, clumping of the cells. There is the peripheral pulmonary pressure, vascular resistance will be increased. Peripheral vascular resistance in the lungs will be increased. Now, according to etiology, pulmonary vascular diseases, as already said, obstructive lung diseases, yes, restrictive lung diseases, musculoskeletal disorders, and hypoventilation syndromes or diseases, which I just mentioned out. Etiological, it is possible. And the duration wise, it is possible to classify. Pathophysiology is the same that I have said, that the pulmonary heart disease, corpulmonale, has already indicated that there is increase in the right ventricular afterload, causing the right ventricular failure. That is the pulmonary vasoconstriction, aortic disruption, pulmonary vascular depth, and increased blood viscosity. More vascular endothelial hyperplasia occur. It means this, and are usually involved. However, most of the time, the right ventricle adjusts to an overload in the chronic pressure. Because there is negative feedback mechanism, in most of the cases it adjusts because of the gradually mounting pressure. According to this is Walkel, the most famous person for the pulmonary hypertension. The pressure overload is the initial step for the changes in the right ventricle. Other factors include ischemia, which is another important factor. The first one is pressure overload. Second one is ischemia. Third, inflammation. Oxidative epigenetics of the pulmonary parenchyma is concerned. The hyperplasia of the endothelium of the pulmonary arteries, etc. And abnormal cardiac energetics. Cardiac energetics means the pressure is mounting from the other side, it is transmitting to the right ventricle. And this is how the blood is going on, viscous, and an embolization occurs. Clumping, high viscosity will cause stasis, stasis will cause injury, injury will cause platelet adhesions, and so on. So the fibrin clot will be formed at the end of this. It will dislodge and will be distal to it, the vessel can be occluded, and high pressure mounting proximally. So the clinical presentation, as for there will be shortness of the breath, there will be possibly wheezing, cardiac asthma, that is called. Cyanosis will be present, ascites because of the right side, jaundice, enlargement of the liver, pulsatile liver possible, raised venous pressure, third heart sound is again on that side, on the right side, in tricuspid area, because of the increased definitely flow from the right atrium to the right ventricle. And intercostal recession, accessory muscle of respiration will overactive, and the presence of the abnormal heart sounds. Dilatation of the tricuspid will cause the transystolic murmur. And again the same thing, the diastolic murmur at the pulmonary area, Graham steel murmur for the pulmonary regurgitation. You will find the Carvalho sound, that is called at the tricuspid area, and Graham steel murmur at the pulmonary area. Management is simple. It is reassurance, first of all. Posture is maintained because pulmonary edema is going on. I have already said about the pulmonary edema, acute pulmonary edema, cardiac. Oxygenation should be given, high pressure, through the cannulae or through the, if it is not possible and disease is gradually mounting, give via intubation. Reduce preload, give diuretics to the patient. Reduce oxygen myocardial demand, give the intrinsic sympathogenic activity, ISA, beta blockers like metoprolol or bisoprolol in a low dose. They will also act as the anti-arrhythmic agent. It reduces the oxygen myocardial demand. And you reduce the afterload by giving if it's acute condition, you give the sodium nitroprusside or the nitrates, or you can give afterwards maintenance should be done with the ACE inhibitors or angiotensin receptor blockers for the prolonged period of time. Bronchodilators are helpful anticoagulants in acute cough and should be used. Follow-up measures, quit the smoking. Alcohol, this is major thing, which is a problem. Environmental pollution is another problem. So masks should be used when you go outside. Abstinence of alcohol, smoking should be quit smoking. It is not easy, this subject. You have to take classes, long-term oxygenation, at home oxygenation, that is called long-term oxygen at the home, ARBs in a low dose. If it is patient is normotensive, can be used as hypertensive high dose. Diuretics, the potassium sparing should be the maintenance dose, like trimetine, etc. Amiloride. Now coronary vasodilators, nitrates are helpful. Antiplatelets, anticoagulants should be used. Antiplatelets are more helpful. In cases of the chronic embolism, you use anticoagulants. Like vitamin K antagonists should be used. Coumarin derivatives, that is called. And HMG co-reductase inhibitors are helpful in this condition. If they are prolonged use, can cause the coronary vasodilatation. Bronchodilators selectively should be used. Epinephrine bromide or any other anticholinergics are helpful. And the xanthines are very helpful, like theophylline. Mechanism of action is five-fold. Nebulizers with the epinephrine bromide or with the SABA, short-acting beta-2 agonist, or tarbutaline. Chest physiotherapy, chest exercises, and you will initiate some activity to this patient, so he can go for the everyday life. Everyday life should be very easy for him gradually. low carbohydrate. Why? Because the high carbohydrate diet will produce carbon dioxide and it will mount in the blood, and more carbonic acid is formed, causing what? And it will cause the respiratory acidosis. Moderate lipid diet and high protein diet. These are dietary measures. I think these will be classified in the general measures and some specific measures and symptomatic measures, and you do for the preventive measures, dietary measures, local measures, surgical measures. These management strategy should be under these headings. Put something here under the every topics, or rather I will say the 5 or 6 I have said. To put these things into these general measures, etc., etc., etc. So that it will be good management strategy. Always try to write on the piece of the paper when you're writing in the file of the patient. Although it looks bad, in the general measure and phala measure and phala measure. In our time, my seniors, or I will say my supervisor, have seen these. There is no time for these persons, professors, to see the file. But somebody has shown him my file, so he called me and said, very nicely written, very nicely. The order will be carried out from it to the other, because the nursing orders will be derived from your orders. If you write it down like this, they can follow it. They can follow your management strategies. I thank you that you have tolerated my tutorial. Inshallah, we will meet it again with the new topic. وما علينا إلا البلاغ. السلام عليكم ورحمة الله وبركاته.